Good morning. Good morning. On behalf of Emeritus, I'd like to welcome you all, and good evening to those in the other side of the world. We have today Professor Adrian Reuben. Dr. Reuben is a Emeritus Professor of Medicine at the Medical University of South Carolina in Charleston, South Carolina, where for 22 years he directed the liver program that he created there in 1993. He retired from the clinical practice in December 2014 and returned permanently to London, UK in March 2018, where he was born, raised, and educated. Dr. Reuben obtained his Pharmacology and Medical Degrees at the University College of London and UCL Hospital Medical School, a Gastroenterology Fellowship at Guy's Hospital in London, and a scholarship at Yale School of Medicine, where he was appointed to the faculty. In 1993, he was recruited to the MUSC to establish a liver program, enhance the Liver Transplant Service, and perform laboratory research. After retirement, his academic activities in hepatology continued, including reviewing manuscripts and research applications, research collaborations, and international lecturing. Dr. Reuben has published over 175 peer-reviewed articles, editorials, case reports, book chapters, and in November 2019, he was presented with a Distinguished Service Award by the American Association for the Study of Liver Disease. With that introduction, I would like to welcome Dr. Reuben, who's going to talk about risk of surgery in cirrhosis. Dr. Reuben, over to you. And you can now share your screen, and I'll guide you through if there is any issues.
Sanjay, I'm absolutely delighted and honored to be invited to give a talk in this very prestigious organization. And I say good morning to people in America, and good afternoon to people in Europe, good early evening in India, and good night to people in Tokyo. So this topic is, on the one hand, is very intellectual. There's been a lot of published work, and on the other hand, is very practical. And I became interested in this a number of years ago now, when we were asked whether it was safe to operate, or when the surgeons wanted to operate on our patients, whether we thought it's safe. And so that's really the title of this topic. Now, one point I want to make at the very beginning is I have included a lot of factual information on these slides and a lot of references. And the purpose for this is because if you want to obtain a copy of the lecture, it's also on the website, but I can also send it to you. There's my email. In case you want to view it at your leisure and go over the evidence for the recommendations that are being made, then this is easier at your own leisure rather than try to do it sort of in real time. One take-home message I think is going to be obvious, and that is for patients with advanced cirrhosis or acute liver failure, the only feasible surgical operation is actually a liver transplant. So let's start by dealing with the non-cirrhotic liver diseases in whom surgery would be contraindicated if the liver injury is in fact very severe. Now we start with the acute illnesses, acute hepatitis, acute liver failure, and it becomes obvious that actually some of these patients do actually have an underlying cirrhosis, and these are underlined in black. And others may actually be transplant candidates. One disease I want to point out to you has become fascinating because alcoholic hepatitis is virtually lethal in surgical operations, even if the alcohol hepatitis is in remission. This was demonstrated many, many years ago. But more recently, what has become interesting is the disease, which is a contraindication to surgery, actually becomes an indication to transplantation in some specialized centers. The risk of surgery on DILI and autoimmune liver disease is still unknown, not been many studies, and largely depends on the severity of the disease. Now we come to the chronic conditions, cholestasis, cholangitis, autoimmune liver disease, and some of these, as underlined in black, may have cirrhosis as well, underlining it. And again, in the others, the risk of surgery is truly unknown and will depend on the severity of the chronic disease, but this has not been studied in any formal way. The third category are miscellaneous disorders shown here, like pregnancy, hemochromatosis. Some of these, of course, will have underlying cirrhosis, so they're not just non-cirrhotic diseases, as you see, Wilson disease, steatosis, hemochromatosis, and so on. And again, some of these, like Wilson disease and acute fatty liver of pregnancy, the latter rarely are indications for transplantation. And it's important to remember that in some of the cases, there are complications. For example, Wilson disease may be complicated by penicillamine-induced poor wound healing, and the surgery or the illness may exacerbate the neuropsychiatric aspects. I will deal with hepatic steatosis in a little while, and at the bottom you see comorbidities which will make surgery complicated or difficult in some of these disorders. As with liver disease, I want to establish that surgery is actually risky and not just a whim of the surgeons who don't want to operate, and try to explain why that happens. I'm going to give you some methods for assessing the severity of the liver disease and other methods for predicting the outcomes of surgery. We'll review a few selected operations, but I cannot deal with every operation, but there are publications on these, and I'll provide a simple decision tree for the perioperative management. Now, it's all about prediction. Now, prediction is very difficult, especially predictions about the future. This is Niels Bohr, Nobel laureate, and Yogi Berra, famous aphorism. Abraham Lincoln suggested the best way to predict the future was to actually make it. As Winston Churchill says, history is going to be kind to me because I'm going to write it. There are some predictions which are notably bad ones. Lord Kelvin, famous physicist of the late 19th, 20th century, predicted that heavier than air flying machines would not work. Irving Fisher, a economist at Yale, my alma mater, suggested in October 29 that stocks have reached what looks like a permanently high plateau. That date actually is notorious because it was a day that the stock market crashed. But one of the best of these bad predictions is journalist Walter Lippmann, who you see there on the front of Time magazine, who says that among the really difficult problems of the world, the Arab-Israeli conflict is one of the simplest and the most manageable. Now, the variables that we're going to use in the diagnosis of the liver status and its assessment are the following categories. One, straightforward clinical features, then specific clinical entities like jaundice and edema and coagulopathy, and the type of operation, very important, and also some particular measurements like PT and INR and viscoelastic measurements. There are a huge number of indices, scores, and classes, which we will mention. You see them listed there. And then it turns out that pressures within the liver are also very useful in predicting the outcome of surgery. They measure the pressure can be an invasive method, such as the hepatic venous pressure gradient, which we will discuss, and the new non-invasive measures liver stiffness, which we can assess the pressure, if you like, by transient elastography. Now, a little bit about the Child-Turcotte-Pugh scores and classes. And you see that Turcotte is printed in red at the top, added to the timeline and to the title of the study from which this timeline derives. Now, it started in 1964 when Turcotte, who was a fellow at Michigan, analyzed the results of Child's operation on patients for variceal bleeding portal hypertension and came up with what they called then the Child-Turcotte classification. In 1973 at King's College Hospital, a study was done on esophageal transection where the resident, Pugh, who was the first author, and hence the Child-Turcotte-Pugh score, which some people abandoned Turcotte's name wrongly and call it the Child-Pugh classification, made certain modifications and gave a calculation that the score could actually be easily calculated. In 2000 at Mayo, the famous TIPS model was devised to work out, the Mayo model was devised to actually predict the outcome of TIPS placement in patients with cirrhosis. And in 2001, this score was then applied to the survival in general of patients with cirrhosis. This was adopted in 2002 by UNOS as the MELD system for liver allocation in the United States. In 2003, it was realized that the level of the serum sodium or the severity of hyponatremia had an adverse effect on outcome. And in 2016, the MELD sodium then was incorporated as the criterion for allocating livers in transplantation in the US. Now, one set of tests that has really largely disappeared are the dynamic clearance tests. This is very nicely reviewed by Pierre-Alain Clavien in the New England Journal of Medicine. The ones I want to point out are the breath tests. And in fact, for a while, I was involved in studies of a isotopic but non-radioactive labeling on methacetin, a precursor of acetaminophen, and measuring carbon dioxide in the breath as a measure of liver status, liver performance, which has largely disappeared. At the bottom, you see that indocyanine clearance, very popular in the Far East and in some surgical units for assessing the structure and the function of the liver before surgery. Nowadays, of course, we have a large number of apps that we can use to calculate indices and scores, and many of these are available online and for download. The one that I especially like is the HepCalc by Gary Pollinard, which actually you can use to calculate all of the indices you're interested in. The Mayo postoperative mortality risk score was developed by Mayo and is available on the Mayo professional website. We developed an acute liver failure prognostic score at MUSC, which is part of the acute liver failure study group. And the one that I like to point out to you, which is in red and in large uppercase, the so-called vocal pen, which I will mention in a while. Now, hepatic venous pressure gradient, very popular, popularized by Roberto Grossman at Yale at the West Haven VA, although this was actually introduced about 50 years previously. There you can see a balloon catheter is inserted into a branch of the hepatic vein, and if you blow up the balloon, you can inject and see the amount of liver that this catheter is measuring the pressures from. To begin with, the balloon is in a deflated state, and you measure what is known as the free hepatic venous pressure, and in this case, it's 10 millimeters of mercury. When the balloon is blown up and wedged into the venule, then you have the wedge hepatic venous pressure, which in this case is 40. So the gradient is 30 millimeters of mercury, which is extremely high compared to a normal, which would be less than 6, usually 3 to 5. Now we come to transient elastography, which can be based on ultrasound by a number of different methods shown there, based on magnetic resonance, and its method is that the collagen or the fibrosis that's deposited in the liver tissues cause stiffness, and this allows for more rapid conduction of external waves, whether these be magnetic resonance waves or ultrasound, and these have actually been used to, number one, identify whether there is advanced fibrosis present, and can actually, the height of the pressure as measured in kilopascals can be used to predict the pressure, as it were, and whether surgery would be dangerous in such patients. You can see the machinery on the right. Now, the Mayo postoperative mortality risk score, very useful. You can see from the form that you fill in, the age and the ASA score, bilirubin, and so on. And this will predict mortality of surgery, shown down below, at 7 days and 30 days, which is really operative mortality. 90 days, 1 year, and 5 years, of course, reflects more the outcome of the patient's cirrhosis. Unfortunately, over the years, the predictive ability of this score has fallen. You see from the red line, 2008, 2010, down to the light blue line at the bottom, has become progressively less useful. Nonetheless, it's something that is relatively easy to measure. The score that I especially like is one introduced by Nadim Mahmoud, a delightful and very talented individual assistant professor in Philadelphia. And here he takes into account not only the scores and the body mass index, but also whether the surgery is an emergency and a particular type of surgery, and this predicts the outcome. The limitation of this method is that it's based on a VA population, and therefore it's mostly men of lower socioeconomic level. However, when the validation, the accuracy is validated, index of prediction, you can see that the first column, the tall blue one, is the vocal pen score, which is better than the MELD and the MELD sodium, and considerably better than the Mayo postoperative score, shown in a sort of orange on the right-hand side. So this is very useful indeed. Now, in terms of whether it's safe to operate on a patient, it really depends when the cirrhosis was known about, discovered, or suspected. If it's been known preoperatively, then obviously you have to assess the risk, the severity of the liver disease, and the risk for surgery. There's no urgency about it. If it's suspected, however, then you have to investigate and refute or confirm whether cirrhosis is present. And here is a nice article that talks about the clinical identification of cirrhosis in a patient with liver disease. It's a rather interesting article. Here is another interesting study by Todd Stravitz from Richmond, Virginia, where he looked at patients with hepatocellular carcinoma who were not previously suspected as having liver disease, and looked at simple markers of liver disease in them, such as low platelet count, elevated ASLT ratio, and so on. And about 50% of these had such markers present. Or if you had any marker, the prevalence was about 80%. So simply seeing this will give you suspicion that the patient may indeed have cirrhosis if you didn't already suspect it. Now, if the cirrhosis is discovered preoperatively, then you postpone the operation, assess the severity and risk, and then reconsider. On the other hand, if it's an urgent operation, it's an emergency, you really don't have that luxury. If it's discovered intraoperatively, which would be a terrible situation for the surgeon, is it because it was missed or ignored, or its significance unappreciated? And then the surgeon has to rapidly assess the risk of continuing the operation, assuming that minimal data are available, such as the bilirubin, presence of ascites, albumin, and so on. Here is a tragic example of a situation in which the cirrhosis was either missed or ignored or unappreciated. These were patients operated, I must stress that this report was by the hepatologists at King's College Hospital, not the surgeons, but laparotomy was performed in 36 patients who were not suspected of having liver disease, even though many of them were jaundiced. The results were terrible: 61% mortality, morbidity, and up to 100% mortality, especially in those with alcoholic hepatitis, which is, as I mentioned at the very beginning. So the question that you might ask is, elective surgery in cirrhosis really that dangerous? Are these just examples, or is it a surgical whim? And here are results from an nationwide inpatient sample in the United States, 22,000 cirrhotics, 4,000 of whom had portal hypertension as defined by ascites, encephalopathy, variceal bleeding. And these were compared to nearly 3 million non-cirrhotic patients. You can see that for 4 major operations on the left, those who had cirrhosis were anywhere from 3 times to 8 times more likely to have mortality, whereas those who had portal hypertension was up to 22.7 times. So yes, elective surgery in cirrhosis is really that dangerous. Adjusted mortality rates range from 3 times to 23 times more dangerous than in non-cirrhotics. I like this group. There's a 6 representative Danish population studies, because in Denmark, they can get the clinical information on almost every patient in the country. And you can see that in these common operations, in either a patient with cirrhosis, the patients with cirrhosis, surgery is 3 to 11 times more dangerous in cirrhotics than in non-cirrhotics. Why is this happening? Well, the burden of cirrhosis is increasing, as you can see, in the left-hand panel, whereas in the right-hand panel, admissions with patient cirrhosis has risen from 60% in 2005 to by 60%, from about 380,000 admissions to 600,000, and surgical operations in that period of time have actually risen from 21,000 to 25,000, a rise of 123%. So patients with cirrhosis are surviving more, but more of them are available, and more of them are getting ill, and more of them are being admitted to the hospital for surgery. Now, here's the MELD score, the favorite of those at the Mayo Clinic, showing postoperative survival in over 700 patients over a 20-year period. And you can see that as the MELD score rises, the operative mortality, which is 30 days, rises, and above a MELD of 10, the rise in mortality is fairly severe, as shown in the little graph on the right, even though it flattens out a little bit when the MELD reaches 20. The 1 year mortality is obviously due to the patient's cirrhosis. And this was actually predicted by a study published by Patrick Northup, again at UVA in Charlottesville, Virginia, showing the same sort of rise in mortality after surgery for patients with increasing MELD. In fact, there was a 1% increase in mortality for every point of MELD when the MELD was below 20, and when the MELD was above 20, the increase was 2% mortality in this study. Another way of looking at it is, what about patients who are listed for liver transplantation? Clearly have advanced liver disease, but on the other hand, they're being extremely well followed and by and large very well looked after. So in this study from Germany, in 148 patients, MELD was distributed somewhat equally from below 10 to above 21. The types of surgery that were performed were major and minor, elective, emergency, and so on, the usual culprits you see there. The primary endpoints of the study were death within 14 days of the surgery, or a rise in MELD, a delta MELD greater than 5, and this occurred in 24% of these patients. And the risk factor for achieving the primary endpoint were shown below by multivariate analysis: ascites, raised white cell count, the use of blood transfusions, and we'll come back to that in a moment, and circulatory support. Interestingly enough, neither long operations nor emergency surgery were actually risk factors for a bad outcome of the surgery. And here you can see the distribution of the changes. 55% of the cases, the MELD actually went down, probably because the illness that was debilitating, which was actually making the MELD worse, was improved by the surgery. 12% there was no change. And to the right, you can see that in almost half of the operations, the MELD actually increased. And in this group, there were 14 deaths, which was 10% of the 24% of patients who achieved the primary endpoint. Now, why is surgery risky? If you look on the left, you can see the range of abnormalities that are present in the liver of a patient with cirrhosis. And I won't read them out, but you can see they range from impaired metabolism and systemic function all the way up to complications of portal hypertension. So what does surgery actually do? First of all, it compromises blood flow and oxygenation. Second, there's impaired hepatic regeneration and a reduction in already compromised renal perfusion. Next, as we've said, there's unnecessary transfusion of plasma blood products with all its complications. Then we've discovered that thin patients, frail patients, those with sarcopenia have a reduced wound healing and poor surgical outcomes. There are a number of other complications that we see here: ischemic heart disease, increased susceptibility to infection, and impaired drug metabolism. And finally, inflammation that is due to either infections or non-infection causes lead to decompensation of cirrhosis. In other words, the development of acute on chronic liver failure, or ACLF. Now, why is blood flow and oxygenation compromised? Simply traction on abdominal viscera will reduce blood flow. There's increased blood loss in patients with portal hypertension and low platelet counts, elevated CO2 retention associated with positive pressure, ventilation, hepatopulmonary syndrome, and pulmonary hypertension. All of these will reduce hepatic blood flow and oxygenation. In fact, anesthesia, even before surgery is undertaken, induction reduces effective hepatic blood flow, as you can see from this study by Cowan and colleagues from the Royal Free from about 30 years ago. You can see the fall in hepatic blood flow that's estimated by, I think, was Indocine and clearance. Now, why is blood transfusion and plasma transfusion increased in patients undergoing surgery? Some surgeons and interventionists believe that in patients with an elevated prothrombin time, or INR, excessive bleeding will occur with invasive procedures and surgery, that fresh frozen plasma will correct the elevated PT and INR, and therefore FFP administration will prevent or minimize procedural bleeding. Unfortunately, these myths are all false. Now, admittedly, there are reductions in coagulation factors, platelet counts, and so on, but there is something that is referred to as rebalanced homeostasis, where all of the factors are balanced by compensations in other areas. Admittedly, although the factors are there in the same spectrum, they are reduced in numbers, so the rebalanced homeostasis is somewhat tenuous and may be perturbed by renal failure and infection, as you see on the right, or altered blood flow. So these abnormalities can lead both to bleeding and thrombosis, and some people do not appreciate how much there's an increase in thrombosis risk in patients with cirrhosis, even though the PT and INR are elevated. Now, there's some corollaries to this. The PT and INR elevation is not a risk for bleeding, but it is a biomarker of liver function because it's both components of both the CTP and the MELD score. Low fibrinogen is associated with poor clot formation, and therefore it ought to be replaced in some way, not just global plasma transfusion. Funnily enough, low platelets can still generate thrombin, even if they're above low as 50,000. Below 50,000, then we have a problem. Protein C deficiency, which is made in the liver, causes thrombophilia and can result in thrombosis and embolic events. And in acute liver failure, there's been the tendency to use acetylcysteine, but this actually reduces the size and activity of von Willebrand factor, and therefore its use theoretically could lead to thrombosis and embolism. Next, I mentioned sarcopenia and frailty. Here you see on the left, survival in cirrhotic patients either with hepatocellular carcinoma or without hepatocellular carcinoma. And you can see from the difference between the upper and the lower curves, the presence of sarcopenia in either case leads to poor outcomes. There's nutrition is reduced in cirrhosis, there's poor healing. Even though patient may be obese, there's protein calorie malnutrition and diabetes. And although nutritional support really makes sense, not entirely evidence-based yet, and we need more information on that. On the right, you can see the effect of a low frailty score, a poor frailty score, on the outcome of surgery, where the patients with the best frailty score, shown above in blue, do better than the patients with a worse frailty score, shown below in red. Now, why does cirrhosis decompensate after surgery other than the factors we just mentioned? One of which is that the hepatic venous pressure gradient can actually predict decompensation and death after resection of a hepatocellular carcinoma. On the left, we see two, and in the middle, we see two studies from Barcelona. The left-hand one, which is the older one with fewer patients, shows that decompensation occurs exclusively in patients with an HVPG above 10, whereas in patients who have HBV below 10 or above 10, they may do fine, but those in whom there's decompensation, Those are the ones that exclusively have an HVPG above 10. The next slide shows the mortality according to the HVPG, where the green is less than 10, the yellow is above 10, and the red line, which is the worst postoperative mortality, shows decompensation and mortality in patients who have an elevated HVPG, but also have elevated bilirubin. Now, how much liver do you need to leave behind? In a normal patient, you can leave only 25% and the patient will recover. But in the cirrhotic liver, it requires at least 40% or more of the liver resected for the patient to survive. In non-cirrhotic patients, a peak bilirubin level of above 7, which is 120 in international units, predicts the outcome of resection as liver failure. And here is another example of the effect of non-hepatic operations, not resection, extrahepatic surgery, abdominal surgery, thoracic surgery, etc., on the outcome. And you can see with the 4 lines on the left that as the HVPG gets worse, it gets higher, then the survival gets worse. And on the right, you can see the progression of HVPG. When it rises above 16, this is when mortality increases, and HVPG above 20 is an extremely high risk for postoperative mortality. Coincidentally, of course, HVPG above 20 is also the risk for rebleeding after variceal bleeding. Now, here is a prediction by the Asian Pacific Association of Study of the Liver, showing that in patients who have a chronic insult, which in this case is cirrhosis, and who are given an acute insult, in which case surgery, the association predicted that this was a risk for the development of acute on chronic liver failure. And indeed, a few years later, this was confirmed in a surgical study from Germany, the development outcome of acute on chronic liver failure after surgical intervention, and published in Liver Transplantation in 2020. So the prediction from APASL was actually borne out. Now, since HVPG elevation is a risk factor for poor outcomes, is TIPS, in other words, reducing the pressure, portal pressure, the answer to the risk of abdominal surgery? And there are a number of studies, and I'm just showing you a few of them. Either the conclusion was that TIPS was a good thing to do, or it was a bad thing to do, or it was uncertain. In a recent editorial last year, the conclusion was that operating under high pressure, there is a place for preoperative TIPS, but only if it's performed early. And so although it's really not yet proven whether TIPS is reliable to do, on the whole, if the patient is carefully considered and it's performed early, then the results in these rare abdominal surgery appear to be better. Now, we mentioned that the different types of surgery, and here's a very nice study by Nadim Mahmoud in Philadelphia, showing that the type of surgery impacts postoperative mortality, ranging from cholecystectomy with better outcomes, and this is laparoscopic, and I'll show you that data in a moment, hernia repair, cardiovascular interventions, and major abdominal surgery. Now, cholecystectomy was once a formidable operation with a mortality of 25%, worse for alcoholic than non-alcoholic cirrhosis, in which alcoholic there seemed to be an 11-fold risk of death with cholecystectomy. But more recently, with the advent of laparoscopic cholecystectomy, situation has improved considerably. Here is a nice collection of 7 studies back in the early 2000s, where 99% of the patients were Child-Pugh A or B. There were only 10 patients Child-Pugh C, and the morbidity was fairly low, and mortality was only 7 deaths, in other words, less than 1% of deaths in all these patients undergoing laparoscopic cholecystectomy. Again, another study in cirrhotic patients, predictors of outcome, and here the best results occurred when These were performed in Charleston A or B with MELD of less than 18. And you can see the benefits of producing this laparoscopic surgery. And if it could not be done in emergency, then a subtotal cholecystectomy or cholecystostomy was recommended. Now, the MELD score been revisited. Here's a small study by Perkins from a few years ago, where he and colleagues predicted that a MELD greater than 8 was the cutoff for performing a cholecystectomy, whereas a more recent publication 2 years ago by Malik and colleagues showed that MELD was a better predictor than Charleston, but complications would arise if the MELD was greater than 13. And so we have 3 different MELD scores as predictors for bad outcome. While we're on the subject of biliary tract disease, obstructive jaundice as a risk factor for laparotomy was realized 40 years ago. If the anemia, elevated bilirubin, and the obstruction was due to malignancy were present, mortality in those days was 60%. If none of these were present, mortality was only 5%. So the question comes up, if there's obstructive jaundice, should preoperative biliary drainage be performed? It seems logical, and retrospective studies were actually very promising. But later, external drainage via percutaneous cholangiography was shown to have too many complications and of no benefit, whereas internal drainage, nasobiliary drainage, or the placement of stents by ERCP was not really shown to improve survival. Here is a study at bottom left, published in the New England Journal of Medicine, comparing surgery to preoperative drainage, and you can see that the early surgery had better outcomes than fewer complications with surgery than biliary drainage. And on the right is a very large meta-analysis of percutaneous biliary preoperative biliary stenting, and you can see that the absence of preoperative biliary drainage just on the left was better and had fewer complications without preoperative biliary drainage than with preoperative biliary drainage. And so it fell into disrepute. So preoperative drainage seemed logical and promising, but as we've seen from these and other studies, not really useful, except for in 2 situations. One, if there's acute cholangitis and pruritus and surgery cannot be performed, preoperative biliary drainage would be indicated for benefit for the patient. The other consideration, if hepatic resection is being contemplated, jaundice is inhibitory of hepatic regeneration. So if the jaundice can be reduced, then hepatic regeneration can be enhanced. So on the left, we have 2 recommendations, one for low-grade biliary obstruction without cholangitis, no preoperative biliary drainage. On the right, high-grade obstruction with cholangitis, severe pruritus, and so on. And nutritionally compromised biliary drainage is recommended, as it will, certainly for resection, help to improve hepatic regeneration. Now, very common surgery, abdominal wall hernias, are very common in patients with cirrhosis, especially umbilical hernias and especially those who have ascites. The morbidity and risk of death was recognized, especially if the operation is an emergency one, and the benefit of early repair, especially if the patient is asymptomatic, has been controversial. So there have been studies of herniorrhaphy in cirrhosis, but these are mostly retrospective or literature reviews, and they very often vary in the focus and the data quality and have given conflicting results. Now, here are studies of hernia repair in thousands of patients published over the last 15 or 20 years. And the results of these studies, I won't go through each of them, but they, on the whole, did poorly. But the conclusion and the recommendation is that in cirrhotics with abdominal wall hernias, even if they're asymptomatic, it's better to repair them early after, obviously, ascites is controlled, rather than wait until it becomes an emergency and is no longer safe. One practical consideration is that if you have a patient with an abdominal wall hernia and you perform drainage of the ascites, even by tips, if this occurs in a rapid way, it can lead to hernia incarceration, and therefore this must be avoided. Now, cardiac surgery. In those centers in which there was extensive experience, you can see that there's a stepwise increase in mortality after cardiac surgery, ranging from CTP class A through to C in the early days at 20%, ranging up to 84%. And other studies in those days gave similar results, as you see in black in the middle of the slide. But unfortunately, more recent studies have shown worse outcomes, 28% mortality in CTP-A, and in patients with ascites versus no ascites, 30-day mortality has been shown to be something of the order of 36% versus only 5%. Morbidity across all CTP classes is shown there. And of course, the MELD score is lower in those who are alive versus those who die with the surgery. So one possible option is to consider combined liver transplant and cardiac surgery, which can be successful and have good outcomes in those centers that have extensive experience. Now, the risk of abdominal surgery in cirrhosis was always considered to be dangerous. There you see overall mortality was thought to be up to 28%, especially in elective situations. Here are 5 studies from 1984 to 2004, where the mean mortality rises according to the Child-Turcotte-Pugh class from 9.5% through to 80%. When the same results are looked at using MELD scores, you can see there's the same stepwise increase as the MELD score increases, although a small study a year later showed that MELD greater than 14 in a way was a better predictor of bad outcomes than the Child-Turcotte-Pugh C score. Now, here are the examples from 40 years ago, 13 years later. You can see the stepwise increase in mortality with increase in the Child-Turcotte-Pugh class. In highly specialized liver surgery units, such as at Mount Sinai, New York City, you can see in the yellow bars that there's been a progressive improvement in mortality after surgery, although the stepwise increase in morbidity still exists. However, in a study just a year later from Freiburg, you can see the same stepwise increase in mortality with surgery from Child-Turcotte-Pugh A all the way up to Child-Turcotte-Pugh C, where this example mortality was 63%. Now, hepatic steatosis. Mild to severe steatosis is associated with 7 to 14% mortality in hepatic resection, and complications are worse when there's more steatosis than less steatosis. You can see the relative rates compared to no steatosis. Mortality greater is, if the steatosis factor is greater than 30%, is almost threefold, and hepatic decompensation after liver resection, not with cirrhosis, is worse with steatohepatitis than in simple steatosis. Mortality rates with bariatric surgery are shown here, terrible in patients with decompensated cirrhosis compared to controls. And so the rule is that bariatric surgery should be avoided in patients with portal hypertension, even though they may give rise to better result of the hepatic function. Esophagectomies, believe it or not, can be performed in patients with cirrhosis with the same stepwise increase in mortality you see there for very few patients, although it's interesting to think about the fact that esophagectomy actually cures varices since the esophagus is removed. Now, there are publications available on all manner of other abdominal surgery, which we don't have time to cover here. But one I want to mention is orthopedic surgery. You can see the same stepwise increase in morbidity and mortality with hip replacement. A more recent study published in 2019 from Michigan showed the outcomes of patients with cirrhosis undergoing orthopedics procedures as revealed by an analysis of the nationwide inpatient sample. Mortality in cirrhotics was 2.4% versus 0.4% in non-cirrhotics, much worse in decompensated versus compensated, as you see here, almost 4 times as great. Now, postoperative mortality, now we've discovered in patients with cirrhosis, is liver disease related, surgery related, and comorbidity related, as you see here. And the list of factors that are under each of these headings are things that we have covered already. And then we have to talk about preoperative assessment. We make a clinical assessment. In a normal patient, there's really no need to check if you can find a normal patient, but we look for clinical history, high-risk behavior, metabolic syndrome, and so on. Laboratory examination and imaging is performed, as we see there, and we measure the scores and the classes and the use of predictive apps, especially the CTP, the MELD score, and the vocal pen, and include the type of surgery in the prediction as we seen by the study presented by Mahmoud earlier. And if the patient's MELD score is greater than 15, or the predicted 3-month mortality of the disease is greater than 15%, then obviously transplantation is an option and should be considered. And so we come up with a decision tree for preoperative evaluation. I must point out that although this is inspired and based on scientific studies, it's still something of an art. On the right-hand side in black, you can see the measurements and the assessments that we make before coming to a decision. If the patient does not have, sorry, let me go back to that. If the patient does not have cirrhosis, CTP class A or a MELD score less than 10, then it's generally safe to proceed with surgery. On the other extreme, if the patient is CTP class C or the MELD score is greater than 15, then surgery should be replaced by some other alternative, or the candidacy for liver transplantation should be introduced at this time. And if it's in between CTP class B or a MELD score be 10 and 15, then you proceed with caution with very close post-operative, perioperative monitoring, depending on all the factors that we've already discussed. Another consideration is there are risk factors for cumulative perioperative complications. You can see here from this study from Mayo, and so this may also be taken into account when you decide about recommending surgery. Now, in patients with cirrhosis undergoing surgery, there are a number of considerations for the use of medications. Fentanyl and sufentanil should be used for analgesia, atracurium and other long-acting doxycurium for paralysis, propofol for sedation, even in patients with acute liver failure who are in the ICU. Short-acting so-called benzodiazepines should be used because of their extrahepatic glucuronidation in the metabolism. Long-acting benzodiazepines must be avoided. Isoflurane and the other anesthetics that are currently used have minimal hepatic metabolism. And of course, we don't use some of the older anesthetics, and be very aware of the use of nephrotoxic agents in patients with cirrhosis because of their impaired renal perfusion. So in summary, surgical mortality in patients with cirrhosis correlates approximately, I've assessed that, approximately with the MELD score and or the Child-Turcotte-Pugh score classes, but these are not necessarily in parallel, and different studies have favored one method of estimation of liver function versus another one. In most operations, mortality rises stepwise with CTP class, but the optimal MELD score varies actually with the type of surgeries. We've seen that. Surgery is contraindicated in acute hepatitis, especially alcoholic, and in patients with a CTP C grade of C, MELD score greater than 10 to 15, and an HVPG greater than 10 to 16. Additional factors for mortality are the age, ASA score, emergency of the operation, hepatic resection, and the type of operation. Portal hypertension is a risk factor for morbidity, especially in patients undergoing biliary or cardiovascular surgery. If no ascites or varices are present but you're still concerned about the level of portal hypertension, measure liver HVPG or liver stiffness. In patients with obstructive jaundice, surgical outcome is not generally improved by preoperative decompression, except when there's cholangitis, severe pruritus, and before the performance of hepatic resection. And with that, I thank you for your attention and turn over to our chairman for further consideration.